everyone. Thanks so much for joining the webinar today. My name is Hannah Nelson, and I'm the coordinator for the National POLST Office. I just would like to thank you all for joining today's presentation, The Role of POLST in the Care of People with Dementia, presented by Ken Brummel-Smith. Dr. Brummel-Smith is a faculty member of the Department of Geriatrics in the College of Medicine at Florida State University. Just a couple of notes. The presentation will be recorded today and available online. And if you have any questions come up, we will address them at the end, and you can type them into the chat box. All right, it is now my pleasure to introduce our presenter, Dr. Ken Brummel-Smith.
Very much, Hannah. Thank you all for joining. And this is going to be a fun topic to talk about because it is so challenging, and I'm sure all of you have had some experiences with this, so I look forward to the questions that you submit to. I think we still have a lot to learn about the best way to do this, and hopefully through these kinds of discussions we'll continue to improve care of people who have dementia. So the main objectives are to talk about the process for discussing advanced care plans and the POLST when caring for people with advanced dementia, but also to talk about possible approaches for discussing these kinds of choices in people with early dementia. The point I really want to emphasize in that second objective is that we do have a window of time in which to engage the patient in these discussions, and if we really want to practice person-centered care, that window doesn't last forever with dementia, so we really need to take advantage of it. So I want to kind of focus attention on that as we move. A friend of mine, Dr. Schneider, who was the former deputy director of the NIA, has called dementia the disease of the century. And the numbers are just astounding in terms of costs that it will be, already is and will be. Right now, the cost for dementia care already exceeds the cost for care of patients with heart disease and diabetes combined. So although it often doesn't get as much attention, I think we really need to be preparing ourselves for the coming wave of people with dementia. The other aspect is that many times these patients are women, and that means then that they have outlived their spouses, may not have caregivers, may not have surrogates who they've discussed their wishes with, and so there's extra challenges because of that. And the other problem is so many people misconstrue the normal changes of age with regards to memory with a abnormal change like dementia. So a lot of people go undiagnosed or are diagnosed in a later stage than they ought to be. This is a slide that shows the projected changes in dementia in states over time. So this is looking at it from between 2000 and 2026, and you can see that the green states, I don't think on my presentation, for some reason this the graph at top is not working, but the green states are the ones where there is the largest expected rise, and the purple states are ones where there's not going to be as much of a rise. But we're talking about huge rises in percentage of people being diagnosed with dementia, and it'd be interesting for each of you to think about your state and where you fit in with that. I think if I can remember the way this graph, and actually I can look at it on a different slide here. Let's get it. So, you know, the green states, the kind of light here. So these states here, if you can see that, Washington, Oregon, Montana, that corner, they're going to have an 81 to 127% increase. The green states are going to have a 49 to 81% increase. The orange or reddish colored states are going to have a 30 to 49% increase. The blue states, 24 to 31% increase, and the purple states, 0 to 24% increase. So there's going to be an increase in just about every state, but some much more than others. The other aspect is, when we're talking about advanced care planning and POLST, is that dementia is a cause of death. It's often not listed, if you look in the literature, as a cause of death, but increasingly I'm seeing lists include Alzheimer's or other dementias as being the sixth leading cause of death. And as you can see, there's quite a large number. But unfortunately, it's underreported because many death certificates are not filled out stating that Alzheimer's is the cause of death. Instead, they'll say they died of pneumonia or cardiopulmonary arrest, which is obviously true to some degree, but I personally report on my death certificates, I write Alzheimer's or Lewy body or whatever the type of dementia is the number one cause of death, just so that people start to pay attention to it. And it obviously is the cause of death in those patients. What distinguishes dementia from all the other causes of death is the long period of disability, especially cognitive disability, that exists before someone dies. If you look at the main causes of death like stroke and heart attack and cancer, those people have maybe a week to a month of loss of cognitive ability before they die, which means that you can engage the patient in a person-centered discussion almost up to the end point in terms of what they want and don't want. So the patient can really direct their care in those cases. But in Alzheimer's, and I'll show you under this when we get to functional assessment staging, there's a very long period of time where the patient can't participate. So we often have to work with their surrogates, and I think that there are different ways of handling that than we routinely do that. The other aspect is, generally in our country, we have this fear of death and disability. I was very struck by the National Alzheimer's Plan, which was one of Obama's achievements, and passed in 2010 or released in 2010. But in that initial plan, there was no mention of death or improving end-of-life care. It was unbelievable to me that that was left off. And there was almost no mention of long-term care services and supports. So this has changed, though. There was a Senate committee hearing on Alzheimer's, which I think started the movement for the Alzheimer's Advisory Group becoming more involved in long-term services and supports and in end-of-life care, but we still have a long ways to go. Our plan, frankly, the United States plan, leaves much to be desired in this area compared to other plans like the Australian plan. Now, in Alzheimer's, at least, it's not true for all the different types of dementia, but in Alzheimer's, there's kind of a predictable loss of abilities, starting with the very complex things like finances and going all the way down to walking and talking. And in a way, this is the reverse of the manner that children develop those abilities. So in a way, this is good because it tells us, as we're looking at someone going through the process of decline with Alzheimer's, what we can expect next. It helps us in terms of not only predicting but advising and guidance to caregivers. And also I'll describe how this plays a role in the person themselves making a decision earlier in Alzheimer's when they still can make. This is clearly shown in the functional assessment staging that Barry Reisberg created some time ago. And if you look through these stages, it shows stage 1 is when there are no difficulties. Stage 2 is the beginning of Alzheimer's, when it is recognized that they're forgetting things and subjective work problems in demanding situations. Others start to notice the problems, and they might have traveling in stage 3. In stage 4, they have difficulty with basic kinds of instrumental activities of daily living, like cooking, sort of thing. Stage 5, starting to have problems, and you can read more about functional assessment staging. There's more in each of these. Stage 5 is when people are having difficulty saying correctly, but they're still pretty independent. But it's really stage 6 and stage 7 when the severe degrees of functional dependence start to set in. And each of these is shown through stage 5, stages of 6, and 6 stages of 7. This will become important in terms of discussing with patients in early dementia about what they would like to see happen. So I encourage all of you to print out the functional assessment staging, that's something that we can use in our discussions with patients. There's another way of looking at that where Eric Larson at Group Health Cooperative in Washington looked at the clinical dementia rating scale, which starts at 0.5 and goes on up to 3, and then looking at the FAST staging. So here's stage 3 of the FAST, 4, 5, 6 with its parts, and 7 with its. And here you can see the years that are more or less expected, so that a person in stage 6 will be in that stage for about 3 years. And a person in stage 7 can live for 6 or more years depending on the types of treatment that are provided them. And this at the bottom shows the mental status exam, mini mental state exam score that is concordant with each of those stages. So a stage 6, you're in the 7 to 5 range. Into that, but then we get down to the stage where they can't even participate in C or a MoCA score after. This is another way of looking at it. So the mini mental state exam is a 30-point test, as is the Montreal Cognitive Assessment exam. I've migrated to the Montreal Cognitive exam. One, because it's more sensitive and more specific, but also because it's free, and now they charge for the MMS, the rights to use it. The normal would be above 27, although this can vary with age and with education. And mild cognitive impairment, which isn't necessarily a pre-stage of Alzheimer's. About 25% of people with mild go on to develop Alzheimer's, but 5% won't. But that's where you have a demonstrable abnormality on these types of tests, but no functional impairments. And you can see the number of cognitive impairment. Early Alzheimer's disease is often spoken of as these numbers, moderate and severe. So this severe Alzheimer's is when we're down in the last stages of 6 and all of stage 7. So if we're dealing with a patient who's entered fast stage 6, they're having difficulty with their ADLs, dressing, feeding, bathing, toileting, then I think that there's a process we can use with patients or their surrogates. And the main point I would say here is don't automatically assume that a person in stage 6 can't participate in these discussions. I've been surprised through the years how often a person who has lost a lot of their abilities can still say something that they care about or they worry about. So I always involve the patient in the discussions, but have the proxy or the surrogate there depending on your state. And in Florida we call a legally appointed decision maker a surrogate, and have to pick one because they never filled out any type of verbal power of attorney. That would be a proxy, but I know in other states it's reversed. So in that discussion, you can try and find out, does the patient understand what situation she's in, and what is really important to her now. And also then to talk about the various choices in medical care and see if she understands the choice. Does she understand what the consequence of that choice will be? All of that goes into decision as to whether this person has the capacity to make a decision. And this is when I'd like to get into discussions about trade-offs. So a trade-off might be, say that the person's goal of care is to not end up being in stage 7. You've discussed total care, or she knows what it's like because she took care of her mother when she was in that stage, and she says, whatever happens, I don't want to end up in a nursing home, completely unable to recognize my family. Then we have to think about trade-offs around that. So, for instance, is it really a reasonable goal to continue trying to prevent a heart attack or a stroke at that point if successful treatment of diabetes is the prevention of heart attacks and strokes, or successful treatment of hypertension is the prevention of heart attacks and strokes? The outcome will be living longer and getting more dementia. So that's the trade-off that they're going to have to think about, whether they want to take that. And some people will say, I want to live as long as possible. Other people will say, no, I don't want to have that threat of having to live the last years of my life not able to recognize. So unfortunately, this is a stage where we see many patients and need to complete a POLST form for the first time at this time. But and clearly a patient in this stage fits the criteria of POLST in having a severe advanced illness, advanced frailty, or not being surprised if they were to die in the next year. So it's very appropriate to complete a POLST form at this time based upon discussion. Interestingly, many people have not completed Advance Directives, even though they do enter these last stages of dementia, and let's say they're past the stage where they can discuss their own personal options. We do know from research that older people, before they develop severe dementia, are pretty clear about their wanting to limit invasive life-sustaining interventions if they don't feel that it will cause them to improve in their health status. And this was a study where they asked older people what they would want if they had dementia and couldn't care for themselves or couldn't communicate. And you can see there the numbers of people who said that they didn't want various types of invasive. So I'm not saying that you should expect someone or demand that they do not want these things, but I think it's clear that already have some strong feelings about this. We just need to make sure and ask them what they do. I mentioned earlier, or at least I had it on the slide earlier, about this concept of compassionate honesty. There are sometimes when a family member will say, don't discuss what's going to happen, or may worry about discussing what's going to happen in the future, that it may harm the patient. But in reality, I think people are harmed much more by going into a serious illness and not having an expectation. So my feeling is that we need to be honest with our patients who have dementia about the eventual outcomes of dementia, but we need to do it in a very sensitive way. So I make it very clear in diagnosing dementia and early dementia that if you live long enough with dementia, all people will eventually develop total dependency. The only way to not have total dependency is to have something happen that would cause their death before that time. That in all patients with dementia, in all types of dementia, eventually difficulty with swallowing occurs. And so the issue around tube feeding, aspiration pneumonia will always be a reality that needs that if people have behavioral expressions, which is a more humane and I think honest way of talking about the so-called psychotic manifestations of dementia. I personally don't believe they're psychotic. I think they're just having dementia and more to being demented. They actually get better as the person advances. And then finally, that virtually everybody with dementia dies of a pneumonia or some other infection or some other disease. There are some people who literally dwindle away because they are given really compassionate long-term care, but most of the time something intervenes. The whole issue around artificial nutrition is one that I think we could do a lot better at. Some states have as many as 70% of demented patients in nursing homes on tube feedings. The whole issue around tube feeding has been an important part of the POLST paradigm from its beginning. And fortunately, we have some new information that I think is helpful to us. So the Choosing Wisely campaign was started by the American Board of Internal Medicine, and actually I should change the slide here. It's 60 societies now have lists of, medical societies have lists of 5 things that you should not do. And the Consumer Reports organization has taken up the charge to try and disseminate these kinds of things in a friendly manner to lay people, whereas the Choosing Wisely campaign from the ABIM is more oriented to medical providers. But the only one that I know of that is recommended by more than 2, and now a third one has been added to this list. The American Geriatrics Society, the American Academy of Hospice and Palliative Medicine, and the American Medical Directors Association all include in their list don't recommend percutaneous feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding. These recommendations are evidence-based. There's no evidence that tube feeding prolongs life in dementia. Hand-fed patients have the same length of life. No evidence that it relieves suffering. It actually suffering. About 30% of demented patients who are tube-fed have to be physically restrained to keep them from the tube, and I can't think restraining a demented person. Doesn't improve nutritional status, even when the nutritional indices like lymphocyte count or albumin levels are measured. It doesn't really mean that they're actually improving in nutrition. So hand feeding is by all measures the most humane and way to provide nutrition to people at the end stage of dementia. So the ideal would be that earlier in the person's dementia, we would have had a very compassionate, honest discussion about this. I give patients a little handout about the evidence with the actual references if they want to look them up on the different aspects of tube feeding, and ask them, do you get to that stage, which you will get to if you live long enough, can't swallow anymore without the food going down your windpipe, is tube feeding something that you would want to have at that stage, given the information that I've just given you? And my patients are similar to the slide I showed earlier, where I can't remember, actually, to tell you the truth, of a patient who said I wanted tube feeding. And that's all framed in terms of their goals. Their goal is to be able to live long enough to recognize family and to be some other way that they see their goal. Then clearly tube feeding isn't going to help them reach that goal once they get to that stage. So what I do is try and take the burden off of families and say something like this. So your mother now has declined in her dementia so much that she can't swallow without food going down her pipe, which would cause pneumonia. This is the final stage of dementia that we're entering. At goals of care discussion, this was something that she said that she did not want. So we are not going to burden her with doing that, and we're going to start hand feeding, continue hand feeding now, but just allow her to eat whatever it is that she wants. Something like that. So I'm not suggesting you use my words, but the idea is to focus that on her goals and on what she expressed before, rather than asking, should we put a tube in her to feed her? I've heard it even said, don't do that, she'll starve, and these kinds of things. Obviously is very difficult for a family to make the correct decision based upon the goal the patient has. Once people are in stage 7, then I think we really need to focus on goals of care. And this is where medication reductions can be done, especially if, and it could even be done earlier, if the medications are not going to satisfy the patient's goals. Like the general goals of discussion that I'll mention at the advanced care planning discussions videos, but they frame goals of care in 3 ways. So they'll say, there's basically 3 things we can do in medicine. We can do everything possible, give you every medical treatment we have available to try and extend your life as long as possible, no matter how much suffering that causes. Or we can limited medical treatments, which will hopefully reverse the acute problem you have, but stop if those treatments are causing your suffering. Or we can give you care and make sure that you are as comfortable as possible, but that may mean a shorter life. So framing it in the goals of care discussion then allows you to make decisions about the treatment of various different kinds of medications. And in my mind, there's only 2 kinds of medicines. There's medicines to make you feel better, treat symptoms, and there's medicines to prevent problems from occurring. So things like statins and hypertensives and anti-diabetic drugs are all to prevent something from happening in the future. And there's little reason for continuing those drugs if the goal is not to live a longer life, no matter how much suffering I have to go through. In fact, if the goal is to not reach a certain stage, like stage 7, then there's good reason for stopping those drugs. If a drug like a psychoactive drug is being used, an antidepressant or especially an antipsychotic, they do need to be tapered. Otherwise, the person can actually have acute side effects from too quick tapering. That also is true for antidepressants. Stage 7 is when we really have to increase comfort. Palliative care should be the primary goal. The eradication of all symptoms, if possible, is really. This is a good time then to, if it hasn't been done, to complete a POLST form, or if it has been done, to update it to make sure that these changes are reflected in POLST orders. Now, what about advanced care planning and POLST in early dementia? Now, one thing that's going on right now is that there is a movement primarily from the neurology community to change the definitions of Alzheimer's. It's now, and dementia is recommended we don't say dementia, that we instead say cognitive disorder. They talk about a state called pre-Alzheimer's or mild cognitive impairment due to Alzheimer's or Alzheimer's disease. And in a way, that's a good idea, but I'm kind of worried about it because I think that it opens the door for not very evidence-based treatments for these early stages. We really need better randomized control trials that show that treatment with any kind of medication in these early stages really makes a difference, and that hasn't been shown so far. The whole idea of doing special SPECT scans or biomarkers and then telling people that, yes, you have pre-Alzheimer's and 15 years down the road you're going to get Alzheimer's, I just wonder about the advisability of that. But that being said, the reality is that more people are aware of Alzheimer's and getting diagnosed early, so this is a growing issue that people are not waiting to the last stages to be diagnosed, and that's a good thing, I think. Think about capacity. People have the capacity to make decisions when they can communicate. If a person has no way of communicating, you have no way of determining what. But if they can communicate, then you have to make sure that they understand the information that's being discussed and that they're able to make a choice and understand the consequences of that choice. That's all that's really necessary to say that a person has decision-making capacity. This is not a psychiatric diagnosis issue. It's not a minimum state score, and I'm going to get into that specifically, but it really is around understanding and understanding the consequences of their choices. But also, the important thing to remember is capacity is specific to the decision being discussed. A person may have lost capacity to manage their finances, but they still have capacity to make decisions about their own life. So not only can it vary with the decision, it also can vary from time to time. Sometimes people do better than other times. So if it isn't very clear the person has capacity, you want to go back and check at other times and see whether they might have capacity. The last concept I wanted to emphasize was this idea of an authentic wish. If a person has lived their life in a certain way and they have a consistency in the way they make decisions, there's no reason to assume that they're going to lose that automatically. I had a patient once where we were doing a study, a randomized trial of the effect of having advanced care planning discussions. And he had early dementia, and we would give him a scripted discussion about CPR, for instance, and go through the whole discussion around that. And at the end, he goes, oh, I asked him, would you want us to try and start your heart if it stopped? And he would say, oh, hell no, I'm 88 years old. When my time comes, let me go. On rounds the next day, we would say, hey, Mr. Smith, do you remember that discussion we had yesterday about CPR? And he'd say, no. Well, and go through the discussion again. And at the end, he'd say, oh, hell no, I'm 88 years old. When my time comes, let me go. So he did not score well on his MMSE. He didn't remember the discussion from one day to the next. But his wish was authentic because he made the same decision given the situation. And this is an interesting study that looked at when people with dementia lose a series of studies. And basically it comes down to if they can't demonstrate they have capacity, then they've lost capacity. In other words, you can't go by a score. It's not based on MMSE or MoCA scores, but these studies showed that people below 18 on the MMSE or 17 on the MoCA had much more trouble demonstrating decisional capacity than people above those. But I have to tell you, I've had patients who've had scores of a 9 on the MoCA. They clearly could understand the discussion, so it's very individual. In New York, there was a case that rose case where the court said people suffering from Alzheimer's are not presumed to be wholly incompetent. So this is important for us to remember as we're having discussions with patients. So in early Alzheimer's, the problem is that we know that future cognitive impairment is certain, but a lot of people don't know what advanced Alzheimer's disease looks like. Even in television and movies, often you don't see the very advanced stages. So the difficulty with using POLST is that by the time the person meets the classic criteria for POLST, which in various states would be things like a serious progressive chronic illness or a life-threatening advanced illness or advanced frailty, the person already has lost cognitive capacity. They're already in at least stage 6 and most of the time in 7 when they fit that criteria. So that's too late to involve the person, him or herself, in the discussion. This was an interesting study by Angelo Volandes at ACP Decisions, which I encourage you to go to that website and to look at their videos. It's just an amazing group of work. But he gave a written description of stage 7 advanced dementia and asked people, what would you want of the 3 levels that we use in POLST forms under Section B? Would you want to have comfort care? Would you want limited additional interventions? Or would you want life-prolonging care? And you can see that about 21% said they wanted life-prolonging care. But then after seeing a video, and these videos are very well made, they don't show the person in a really negative light, but they show them in a very compassionately honest light. And you can see the change went to none wanting life-prolonging care once they saw what it looked like. So I think the videos have a great provide a great opportunity for having a more honest discussion around what choices the person might have. A couple of other studies. Marcin used vignettes, descriptive vignettes that were written, and found that those with mild to moderate Alzheimer's were able to express a reasonable choice. When asked, though, to provide a rational reason for choices, 50% of people with mild cognitive impairment, none of those with Alzheimer's, could provide a rational choice. But when they were asked to provide an emotional reason and the consequences of their choice, all of the people with MC, 40% of the people with Alzheimer's could. So this, to me, highlights the problem with some of the old-fashioned ethical definitions of decisional capacity, because it talks about being able to make rational choices. People don't make these decisions based on rational choices. They make them based on emotional reasons. And as long as we can be clear that they understand the consequence of the choice, in a way, that's better. Matthew Mazie at New York did a similar kind of study that 72% of people with MMSEs below 20 could name a healthcare, that should be healthcare surrogate, could name a healthcare surrogate who they felt would follow their wishes. So what I'm suggesting is that we have this possible approach where we engage all patients with early dementia in an advanced care planning discussion. We make it a routine part of what we do. And that during this we elicit goals of care and we help them complete an advance directive and name a healthcare surrogate, and we have a discussion about the future use of POLST. So in goals of care, we want to use open-ended questions to ask them what they see as coming. I've put on here a few different ways that goals of care can be elicited. Respecting Choices out of Wisconsin has a great set of tools for discussing goals of care, as does the California Coalition of Compassionate Care. The Go Wish card format, these are a set of 36 playing cards that you can pick wishes that are important to you and talk about them. And then there's online resources, which is more than just goals. It's a whole way of completing an advance directive, like Prepare for Your Care out of Stanford and mydirectives.com, both of which have sections for goals of care. I've done mydirectives.com because the nice thing about it is you can also upload your POLST to mydirectives for states that don't have registries, but also you can video yourself. And at least in Florida, we always talk about the sun from New York. You know, you've dealt with a patient and she's taking care of her mother who has advanced dementia, and she's doing all the hard work, and then the son from shows up and, oh, I want everything done after you've surrogate and the patients. So I think, you know, for my directive, since it allows you to video yourself, you could say, don't you dare put me on a feeding tube, and I think it would be an amazing. I just thought I'd show you I filled out mydirectives.com. These are my own personal priorities. I asked you to fill out your priorities, and these are the ones that I chose based upon 30 plus years of doing geriatrics. But obviously I'm not suggesting these are for you, just to give an example of what you can put in these kind of documents. When you're doing advanced directives with the surrogate, the important thing is not to just fill forms out. It really is a matter of discussing them, and that's where I would suggest watching the Volandes videos with the surrogate and the patient together so that they can actually have their discussion right in front of you, facilitate that process. I think it's very important that a person experienced and knowledgeable about dementia care be involved in that process so that people understand the full range of treatment options. And then to discuss what to do about coexisting medical conditions. As I said before, when you think about it, if you have a person with early dementia and they have other comorbid medical conditions, the successful treatment of all of those other comorbid conditions, if they're prevention-oriented, means the person will live longer. Longer, they'll get more demented. That brings up the question of what's the goal of care. It's not just a matter of globin A1C reduction or a blood pressure control number or some other surrogate measure. It's really a measure of what is the goal of doing this prevention treatment. So when discussing POLST in a patient with early dementia, I think it's very important to frame the discussion. What is it that you want in terms of your goals of care right now for the next period of time? Might be 5, 6 years. What happens when you enter into the moderate stages where you can no longer drive, where you can no longer work, but where you can have a high quality of life with the right kinds of supports? And what will happen when it becomes severe and you become dependent on your family for feeding and each of those has probably a different set of goals and decisions affecting. Make sure that the person understands the consequences of their choices in each of those portions of their life. Also make it clear to them that they have the right to change their minds whenever they want. There's obviously issues in a demented person changing their mind discuss in the discussion, but in general, I think the basic principle is we always listen to the patient. Then consider recording the discussion. I've been using my iPad to actually record that using FaceTime. Using the camera, and then you can actually export that to the patient. Oops, my slides went away here. Oh, here we are. It's done. So what I've been experimenting with, and we don't have clear guidance either nationally or through good studies yet, although this is a study that I hope to start, is what would it be like to complete a future pulse? So on some of my patients, I actually complete a pulse form, but I don't put a date on it. I write when I'm in fast stage 6C or whatever it is that the patient decides. And to link that decision to a goal of care. So the person might write, in order to avoid permanent nursing home placement, I would choose comfort care over aggressive treatment of other medical conditions. And so the patient might say, right now, my present pulse, the dated one that they have on the chart, is PR, limited additional treatments, and no tube feedings. But when I'm in fast stage 6, it would be no CPR, comfort care only, and so you'd change the pulse based upon being in stage 6. So in summary, don't ever assume that the patient with dementia is unable to engage in advanced care planning. Try the discussion around these issues to see whether they understand the consequences of their choices and can give you reasons for making that. Remember that true person-centered care is founded on the person's goals of care, not upon external measures like blood pressure or other types of surrogate measures. We need to be the ones to bring up these inevitable choices to them. They are waiting for us to do this. This is our responsibility. And at the bottom of everything is committing to providing comfort no matter what choices are made. This paradigm is that comfort care is provided even when someone is full treatment and CPR. So that's pretty much it, I think, for the presentations, and we have lots of time for questions.
Great. Thank you so much, Ken, for taking your time and presenting that important topic to us. Let's see. I did just get 2 questions came in, so I'll go ahead and read off the first one. In order for a POLST program to be endorsed, the form is required to clearly state that food and fluids must be offered if feasible, regardless of level of care chosen. So that sounds like it is okay for this population. Is that correct, or is a modification needed on a POLST form for this population?
No, that is correct, and I don't think a modification is needed for the POLST form. offering is not the same thing as forcing, and offering is not the same thing as being accepted. So if a person is in the end stages of dementia and is unable to feed themselves, then we would want to offer sips of water and spoonfuls of food. And if they want that, then they'll show us that. But if they don't want that, that's okay. We don't have to force it on them to either meet the POLST guidelines or just medical care. So I don't think there's any problem with the concept that it's offered. I think where it could get into a problem would be in a person who has decided to voluntarily stop eating and drinking, and there you have this is a different topic altogether, but voluntary stopping of eating and drinking is a perfectly legal intervention in the United States, and many hospices support patients through VSED. And in those situations, what I usually tell my patients is you can change your mind at any time. Usually that's never done by someone with dementia, by the way, so it's not really the topic of discussion here, but it's for someone who's not demented and they've voluntarily decided they're going to stop eating and drinking. But even in that circumstance, what I tell them is, I'm not going to be asking you whether you want to change your mind, but if you want to change your mind, you tell us. And so I asked nurses in the hospice not to be offering it to those people since they've already voluntarily decided they don't want it, but that if they say they want it, to definitely give it to them.
I guess I have a follow-up question with what you just said. Do you find that people often do change their minds when they make a decision regarding food and water or food and fluids?
Demented patients, especially if they're in the end stages, don't change their minds. It usually is the family that wants. And if the family wants to change their minds, I think it's really important to understand why they feel that. Frankly, there's good hospice care and there's not so great hospice care. There's sometimes when people's suffering is not adequately their palliative care needs are not adequately met. And so if a person is in pain or having dry mouth or any other symptom that is bothering them, that might be a reason why the family is upset and wants to change their minds. And I think it's really incumbent on us to make sure that the palliative care is as stellar as possible. But in VSED, there is little research on that, but the last time I looked at that, I think about 20% of people who start voluntary stopping of eating and drinking, that's not the subject of dementia, since it's, well, it could be. I mean, a person could decide to do that early in dementia if they wanted to, but by the time they've lost decision-making capacity, they can't make a voluntary decision, so it doesn't advance dementia. About 20% of people who don't have dementia and do VSED do change their minds and start eating again.
All right. Another question that came in. You have discussed dementia and AD is essentially synonymous, whereas I've considered dementia the more all-encompassing term. Please revisit the distinction.
So dementia is an overall term describing the syndrome of memory loss and loss of other cognitive functions like executive functions, abstract thinking, judgment, decision-making capacity, and usually some type of neurologic changes like apraxia, where you can't figure out how to do steps, or agnosia, where you don't recognize objects, or aphasia, where you lose language skills. So it's an all-encompassing term that shows something in the brain is going wrong. And then there are different types of dementia. So Alzheimer's is the most common type of dementia. About 70% of all dementia in the United States is due to Alzheimer's. And then there are other common types like dementia with Lewy bodies, temporal dementia, vascular dementia, Parkinson's dementia, Pick's disease. So it's a good thing to be clear on the difference between them, but all Alzheimer's are dementia, but not all dementias are Alzheimer's.
Great, thank you. Another question for you. When discussing POLST with a patient, do you recommend conducting the discussion with immediate family or healthcare providers and patient only?
I highly recommend discussing with the family, but two reasons. Number one is these are family issues, and the care is going to be provided, if the person's lucky enough to have a family, by the family, so they need to be on board with the care plan. Still, the person has the right to exclude their family if possible. They have the right to exclude their family, and if that happens, then I engage the patient in a pretty discussion about why it is that they would not want their family to be involved. The opposite is true in family members who say to me, whatever you do, don't tell him he has Alzheimer's. He's been afraid of that. I think family members have a right to say that, and obviously their input is key because they know the person better than I do. But at the same time, I have a responsibility to the patient to be honest with them. So I try and negotiate that with the family. But no, if reason to not include the family, unless for some reason I thought the family was or something like that, and then other things going on that.
Thank you. We'll go to another question from Marianne. With payment now for ACP POLST goals of care discussion, is there a concern that such discussions will be inadequate to appropriately assure the patient's preferences will be accurately established, especially in a dementia situation?
I don't think so. I think that these, I know I should have said this before, is these are not one-time discussions, especially in dementia where it occurs over a period of 7 to 15 years. The discussions need to be revisited. They should be revisited anytime there's a significant change in the health status or in the social status of the person, like a divorce or a change in living situation, and then probably periodically. I like to see patients with dementia at least once a year, in part because I want to measure the progress of their dementia. That's important in prognostication and in treatment decisions. And so that gives the opportunity to do that, and you can use one of the discussion codes with a regular CPT code. So no, I don't see any problem with it. It does need to be revisited, and you can use the same codes to revisit them after. So I forget the exact number. It might be annually on that. But the other aspect is you don't always need to use those codes, and I've given talks before about how you can use prolonged service codes, or really you can use a regular visit code and just say in the code that you spent more than 50% of the time in face-to-face counseling, and that way.
Thank you. We'll try to get 2 more questions in here. The next one from Amy. Has there been any confusion with EMS and having the POLST filled out with the patient not having the threshold conditions?
Yeah.
Okay.
That's a good question, and the idea of filling the POLST out in advance is not actually to use it in the same way that we normally use a PULSE, where it be used with the EMTs. That's why I was saying you have to be making the decisions for the PULSE form based on the present situation. So if a person says, look, if something happens to my heart, let's say they're in early dementia, And they say, if something happens to my heart right now, I don't care. I'd rather go now than even take the chance of getting to moderate dementia. I would still want to understand that better. But let's just assume after a long and in-depth discussion that this person is very clear that that's what they want. I probably would fill out a pulse that has no CPR on it. But in most cases, this when I'm in stage 6 idea, instead of the date, is a place marker for the new pulse that is going to be filled out when they're in stage 6. And that's when the surrogate is going to be the one signing the pulse form that has today's date on it and shows the DNR order on it. So what I'm using the pulse form is a framework for having an in-depth discussion about what this person who we know is going to lose their cognitive abilities in the future to be able to have a say of what happens to them.
Thank you. So I think maybe the last question for the day, this one from Lisa. What is your thought for residents who have already completed a state out-of-hospital DNR order, and then the state has created a form similar to the POLST? We're approaching these individuals to discuss the various options of the POLST form. Some conflict, as some of these residents have very difficult time discussing this in the first place.
Well, I think there's two kinds of parts to that question. State DNR form usually is just DNR. And we know from the evidence that just DNR forms have a risk of decreasing palliative care. This was a study that Susan Hickman did looking at people who had DNR orders or POLST orders in the same state. So in general, I would always try and convert a state DNR form to a POLST form because POLST has been shown to increase the number of ways that people can get palliative care. And it's just a better form and has more information about the kinds of things that a person is going to have to be facing. So although it's difficult, I would say chin up and try and get the POLST form completed because it's going to be a much better form for managing difficult decisions later in life. I know that those discussions are difficult, but I think that they've got to be had, and the POLST is the safest way to protect patients.
Thank you. And I did have one other question for you. Someone had a question about the Bolondis videos, if they can be purchased or where they can be accessed.
Some can be accessed on their website, which is ACP Decisions, all one word, Advanced Care Plan, acpdecisions.org. And if you go there, there are some of the videos that they make available to anybody who wants to watch them. The actual purchase of them, you would have to contact ACP Decisions about it. They have various different business models where they work through health plans, and health plans can purchase the license to them, or medical groups and that sort of thing. So you would need to talk to ACP Decisions about it.
Great. Well, thank you so much for your time again. I think we just hit the hour, and yeah, we really appreciated listening to your presentation today.